So this patient presented with pain to biting, pain to percussion on tooth number 7 there, and I remember it was lunchtime, and I thought, okay, this will be real quick. We can fit her in. I can take care of this and won't slow us down too much, and we'll get her out of pain. And this is a 35-year-old who has done a great job of maintaining her teeth. She doesn't have any perio anywhere in her mouth, and she's very aesthetic conscious, and you can't blame her. And I thought this was going to be quick. And I have this in the root fracture section of the talk, so you probably know where this is going. But looking back at this just one PA radiograph, I should have known better. Because if you look, her bone definitely is not level here. She has lost bone around this area of tooth number 7. And if you look at her pulp space, it comes down and then it kind of necks in this area here, right at this cervical line, and then it gets larger again at the apex. Probably something here was irritating this pulp before it died the rest of the way. But I really did not pick up on these subtleties as I started working on her. So I got her numb and I put my 9A clamp on this tooth, which creates a little traction on the rubber dam. I accessed through the lingual of the tooth to gain entry to the pulp space, and as I did that, the crown of the tooth shot across the operatory as I then had dislodged it from just the soft tissue that was holding it in place. Remember, we had pergo floors at that time, and it seemed like that crown rattled around on my pergo floor for 5 minutes before it finally stopped. And then I looked at her and I looked at the x-ray, which we always do when we're confused. And I looked back at her and I said, have you ever had trauma to this tooth? And I'm sure she was thinking, well, not until just now. But she actually did remember falling off her bike and hitting her mouth and getting some stitches in her lip when she was about 12. And I think at that time she probably did get some sort of partial horizontal fracture of that tooth. That was probably what led to it requiring root canal treatment when she came to my office, and then led to the crown being launched across my operatory by the traction created by the rubber dam. So now I had kind of a mess. Remember, I told you she was rather aesthetic conscious, so we were able to clean and shape the inside of the root by using some of the Oroseal to get a reasonable amount of isolation in a split dam. So once we did that, we had taken care of her toothache. Now we needed to give her something to smile with. And I thought, well, gee, I have this crown sitting here, and it, has a reasonable color match, and it looks just like the thing that was there 10 minutes ago. So maybe I can use that. So I enlarged my access through the natural crown. I placed a post inside the root that was, still in her mouth, and then we picked up the post with composite, so that we then had this temporary crown with a post sticking down into her root, and I cemented that, and then that's how she left that day, and I thought that looked pretty good. But now we have a restorative problem where we just don't have much ferrule. So we had her back, and we cemented this post inside the root. It's actually just a hook that I bent. And then again, we still have this crown, so what I did was thin out the lingual of the crown and put an orthodontic button on the lingual. And then we bonded that to 6 and 8 so that we could then pull up the root on tooth number 7. And this is your standard extrusion case. And this actually happens real quickly. So with this elastic in the button on the lingual into the hook that was temporarily cemented inside the root, we're able to pull this up pretty quickly. Again, it's not like traditional orthodontics. We're not moving a root through bone. We're really just stretching the ligament, and then the bone will come along with it. So this is what we had after moving a little bit. And remember, this little dot of sealer was at the apex when we completed treatment. So now we're starting to get a little bit more of a ferrule. And this is before we started moving it up on the left. And now this is after we have moved it up. It's now flush with this pontic I had made. It's important to do periodic fibrotomies when you do this. Otherwise, just the bone comes with it and you don't get increased ferrule. So now this is what we have, and we're ready to have her get her crown made. This was a similar situation where this patient was referred to me to do root canal on tooth number 23, and I'm thinking that must be some mistake. There is no 23, but it was there. She had been in an auto accident, and she was a smoker, and she did not want to have an implant. which would be a reasonable way to go. But implants are tough to do in the mandibular anterior because there's not a lot of room there for just one implant. So we did kind of the same thing with her. We were able to clean and shape that area using an electrosurge to get access to the root. We then actually had 2 canals, so we cleaned and shaped both of them, cemented this hook inside there, and you can take a look where this root is right now. It's subosseous. But we had this lingual bar in there, so we just, again, wrapped an elastic up over that bar and hooked it in, and that root came up real fast. Remember, this was below the osseous crest, and now it's a solid 6 millimeters above, and that was in 3 weeks. Again, this happens fast, and you're not concerned about resorption by moving these fast because we are not moving them through bone. I think sometimes orthodontists get a little over complicated with this. We don't really need much more than a tooth or 2 on either side to have enough leverage to move a tooth where we're just stretching the ligament. One thing we didn't do enough of with her was this fibrotomy to keep the bone from coming with it. But I think that's a good illustration of what I talked about in the beginning of this lecture, the magic of teeth. How it's not just a dead foreign object sitting there. There is dynamic interplay between the cementum, the ligament, the bone, and the whole periodontal apparatus that we can harness in our favor and use that to then have it be a more biologic solution. So then we stabilize that for a couple months, complete the root canal treatment. This is not periapical radiolucency, that's just where the root was left behind. If you look at this area, you can see after a little while, the bone does come up more, and there was a little bit of relapse of our treatment, but we were able to do more soft tissue management there, and that was 3 month stabilization, and this is 6 month recall on that. So this really looked like quite a hopeless situation, and by just being creative and persistent, and again, harnessing this magic of the attachment apparatus to keep teeth there, this is a great long-term solution. She never had to go without it. Well, she didn't have to go out of tooth very long, and we don't affect anything else in the area.